Hi, I am ESMO 2025 and I would like to tell you about 3 abstracts presented during the Congress. Really some practice changing data and information. The first one is ENGOT OV65B Keynote B96. This is a randomized double-blind phase 3 testing the addition of pembrolizumab to weekly paclitaxel with or without bevacizumab in patients with platinum-resistant recurrent ovarian cancer. The trial wanted to demonstrate if the addition of pembro could improve progression-free survival in the CPS 1 and higher population and also in the intention to treat population. The results of the interim analysis 1 showed a statistically significant improvement in progression-free survival in both populations. Also, at interim analysis 2, there was a statistically significant and clinically meaningful improvement in overall survival for the population with CPS score of 1 and higher. And also, it was announced that this statistical significance is also now for the overall population. I think this is very important because we have here with this study a median overall survival in the Pembro arm of 18 months, which is one of the longest ever reported in a population of patients with platinum-resistant recurrent ovarian cancer. And this was 4 months longer than the placebo control arm, where the median OS was actually 14 months. The toxicity profile was manageable. So the conclusion is this is the first trial demonstrated that superiority in overall survival for the addition of immune checkpoint inhibitor in ovarian cancer, and this should become a new standard of care in these patients. The second abstract I want to report is about the Rejoice trial. So we are talking now about the ADC. It's an ADC targeting Coderin 6 with a payload which is a TOP1 inhibitor. The results presented here at this Congress was the dose optimization of this compound. 3 different dose levels were tested, and the response rate was very high across all these dose level, was 50.5%. Again, we are in a platinum-resistant population with up to 3 prior lines of therapy. And looking at the toxicity profile, the most important were anemia, asthenia, and of course, this led to the decision to pick up the most suitable dose, which was the 5.6 milligrams per kilogram. So this was, at the end of the day, the conclusion of the study. This is very important because now a phase 3 is planned and will start hopefully very soon at the beginning of next year. And this compound will be tested against the standard of care. Finally, I want to report on the ATTEND study. Now we are moving to endometrial cancer. The ATTEND study tested the addition of atezolizumab to chemotherapy with carboplatin and paclitaxel in patients with advanced, persistent or recurrent endometrial cancer. The trial was published, reported the primary endpoint of progression-free survival, which was positive in the intention to treat population and also in the particularly in the DMMR population. Now at this Congress, we reported actually the final overall survival, and this was a co-primary endpoint. So the endpoint of the study was PFS and OS. And unfortunately, we could not demonstrate an improvement in overall survival for the overall population. However, if we look at the DMMR population, there was a clear benefit in overall survival with a hazard ratio of 0.49. And also was interesting to see how there was an interaction between the benefit and the Asian population. In fact, for reasons which still we don't understand completely, but it looks like atezolizumab performed particularly badly in the Asian population compared to the non-Asian population. And in fact, if we look at the data, even at the overall survival without the Asian population, probably we could have reached even a statistical significance. I think this trial is in any case very informative because it confirmed the value of immune checkpoint inhibitors for sure in the dMMR population, and this of course is and will remain a standard of care in these patients.